We did go to New York to get that second opinion, and I was very fortunate to meet Dr. Roboz. It was tough. My wife and I and my daughter were there, and we got pretty much the same story. Dr. Roboz did a lot more than the original oncologist. She asked me about my exercise. She did a complete physical. And the bad news was she then said, "You've got AML, and you're going to have chemotherapy, and you're going to have it here in New York City." So that didn't seem all that good. Our life had really changed permanently. But Dr. Roboz said, "Okay, you can have your chemotherapy out in your local cancer center." It's a good cancer center we have out here. And I was all set to start chemotherapy on a Monday. This is January of 2015, and Dr. Roboz is away on a vacation, a well-deserved vacation, I now know. He called us Sunday night and talked to my daughter and said she had done some special testing and that I had a special mutation that might be treatable by an alternative treatment than the standard of care chemo. So she also was very clear, Dr. Roboz was very clear, it was not her decision, it was ours. So that was Sunday night. Monday morning, we skipped chemo and went to New York City. And to make a long story short, that Monday morning, we signed up for a clinical trial based on, not on anybody's recommendation, but just based on the fact that Dr. Roboz called. And we signed a stack of papers and we started a clinical trial. So that's the good news was I started that and I simply went home. I lived at home. I lived quite a normal life for a week or two. And then I spent 10 months in bed.
Before we get to your 10 months in bed, let me unpack a couple of things there, because that actually is your specific side effect profile is particularly unusual. So let's get there. Let's get there in a second. I would say there are a couple of very key aspects to the kind of initial parts of what you described. And the first is the term chemotherapy. So chemotherapy basically just means medicine. It doesn't tell anybody very much about what is actually involved in AML treatment. And I think that in and of itself deserves a moment of discussion, because historically, chemotherapy for AML has been divided into what's called lower intensity and higher intensity treatment. Not very specific, but basically what that meant was that historically, and when I say historically, I'm really talking about the last 6 decades or so since we've been able to get patients with AML reliably into remission, that has taken place with a combination of basically 2 drugs, an anthracycline and cytarabine, which form the so-called 7+3 regimen. That is an intensive chemotherapy regimen that typically keeps patients in the hospital for 3 to 4 weeks. And that has had historically, and still probably has for most patients, the highest rates of complete remission. Not talking cure yet, but just getting the disease into remission. You got to get into remission in order to have your quality of life back and to extend the length of your life. And what remission means is actually reducing the leukemic burden in the bone marrow such that normal recovery of more than 1,000 infection-fighting white cells and more than 100,000 platelets can come back so that your peripheral blood has normal blood counts, but there are fewer than 5% detectable blast cells under the microscope. That has historically been the definition of remission. And that is not divided by age. It's not that if you're 60, you're young enough, and if you're 70, you're too old. That's not really how that works. The application of that chemotherapy is based on our impression of the ability of a patient to tolerate it. And you could have handled that chemotherapy. I would have had no problem giving you standard chemotherapy. However, you were also at the borderline of being able to respond due to the nature of your disease. We thought you might have a chance of responding to what was called lower intensity chemotherapy, which is a hypomethylating agent, either decitabine or azacitidine. These drugs are given in usually in an outpatient setting. The probability of toxicity is lower, but the probability of remission is also much lower using a single agent of one of these. So the original thinking for you could have gone into the hospital and had intensive chemotherapy, but we were going to take a shot with the lower intensity approach and see what happened, with the idea that if you were lucky and got into remission, and not that many people get into remission with that type of single agent therapy. Things have changed a lot since you were diagnosed, but at that time, we were going to see if you would get lucky and get into remission, which you probably wouldn't, and then have to switch you over to the more intensive option, which would have put you in the hospital for a month. Now, things got interesting because we were at that point doing a lot of what's called next generation sequencing, or looking for potentially targetable mutations. AML is complicated, the biology is complicated, and we knew for decades that this sort of one size fits none chemotherapy paradigm that I was describing to you, of more intense chemotherapy versus lower intensity chemotherapy, these were two hammers, a stronger hammer and a lighter hammer, but that didn't have any particularly personalized or targeted elements to them. And there had been an explosion of new biology data in the lab suggesting that there were certain AMLs with certain mutational patterns that might, emphasis on might, because we didn't really know at the time, but that might benefit from a targeted therapy. And you landed in my office at one of those miracle moments where we knew how to do the specialized testing. I did it for you. I didn't want to get your hopes up initially that you were going to have necessarily a targetable mutation, because they're actually pretty rare, unfortunately, in AML. But then you had it. And actually, my first call, I think, to your daughter, I'm reasonably sure I had a ski helmet on at that point, because I seem to remember screaming at her with some weird microphone in my ears that I have information that I've got to talk to you about for your dad, because it turned out that you did have a targetable mutation in something called IDH, or isocitrate dehydrogenase, which was a pattern, a mutational pattern, and a part of the biology of AML that had been exploding onto the scene. And you were eligible for a clinical trial, and you wanted to take that leap. I think you did kind of have an understanding that maybe this was something cutting edge and new and exciting. And even though the exact pathway was kind of a bad memory from organic chemistry, you decided to take that leap and you started onto a brand new clinical trial. And I think that the key messages for the general audience is AML therapy used to be lighter chemo versus harder chemo. That's actually very, very different right now. And we do try very hard at the beginning of the diagnostic process to get as much information about the biology of the disease as possible to see what is the probability of remission with any of an assortment of agents that we have. And now we can launch into, okay, you came in, you met me, you got the cool testing, you had the mutation, and we had a slot for you on our investigational trial, which you took. And now the mystery thickens, the plot thickens, because you started talking about being in bed for 10 months. And I think we have to be specific to the audience about what your experience was and what you went through, and then to generalize that a little bit more into what would be likely for most patients. So tell what happened when you popped the first pill.
Well, it was really a relief that I didn't have to have the in the clinic chemotherapy. So the life seemed pretty normal. I took a pill, and I didn't know the first month what was going on, and so we were getting blood tests all the time. I was going into New York a couple of times a month, and we were finally starting to see what I thought was impossible, that those things called blasts in April started for the first time to go down. And so when I said I didn't have hope, that was only for a couple of months. I didn't give up, but hope returned in April. There were side effects. I was pretty weak. Lots of different problems. I had what appeared to be jaundice and red spots and digestive tract issues. But this clinical trial was keeping me alive. And now one thing was a problem. I couldn't physically eat. And Dr. Roboz was a little concerned about that and asked me to try a saltine, which I couldn't eat. So I survived on a chemical nutrition. 6 or 7 of those a day seemed to keep my weight close. I lost 45 pounds. But by September and October of that year, after a very tough 10 months, I started to feel better. And Dr. Roboz was noticing that I didn't have to come in quite as often.
So I think that this is, it's an important moment to kind of put into context your experience compared to what it might have been like with other therapies and compared to what other patients would have. And this is one of these moments where it's so hard because from the doctor point of view, obviously we want to be completely in tune with what you're experiencing and how incredibly difficult side effects and symptoms of anything are. And I think most people know if you just take an antibiotic, you can feel terrible on that. But from my perspective, what you were experiencing was actually so off the charts positive and incredibly, incredibly better than what you would have had on intensive chemotherapy, that I remember to this day that I had to walk this fine line of, on the one hand, you were going through so much and you did have such incredible food aversion. And I remember talking to Dorcas and trying to figure out what we could do to get a morsel of anything into you because you hated swallowing. You just couldn't keep anything down. You were feeling so lousy. And yet from my point of view, you're on what we were viewing as a miracle drug, which was a single agent pill that was putting other patients into complete remission. On this trial, we were starting to see incredible activity of the drug. So the question was, how could we reconcile the fact that you were feeling so lousy, but I can't slice you in half and show half of your body what the other half would have been going through on chemotherapy. You were still home. You weren't in the hospital. You weren't having the horrendous and life-threatening types of infectious complications that sometimes patients in your age group especially would go through with intensive chemotherapy. All of those things weren't happening, and we were seeing positive results in the blood. So how do we get you through all of this? It's so hard because I was looking at you compared to all of these nightmares that I had seen throughout my entire career and was watching you with wonder transform on this drug. And yet your experience was compared to the rest of your life where you had been feeling fine and energetic and running around and running a business and doing 5,000 things. And compared to that, I think you felt unbelievably awful and were probably wondering if you would ever get your normal life back. I think one extraordinary aspect about what you went through that patients need to think about is that when you are given informed consent documents for a clinical trial, and you referenced that, you actually said you signed a stack of papers. It's a very weird process because you get a stack of papers with 9,000 potential side effects and issues when you're starting an investigational drug. And yet actually the informed consent process doesn't require a reading of an itemized list of side effects and potential toxicities for standard therapies. And I think about this a lot because patients end up being much more frightened of an investigational drug because they get a stack of papers with every possible side effect known to mankind and half of the ones that aren't known to mankind. And yet there isn't a similar stack of paperwork for the conventional therapy. And I think about it through my career so many times that people end up, it's a mischaracterization of the treatment because they end up more frightened of the investigational drug because of the paperwork. And somehow the conventional chemotherapy, because it's conventional, doesn't get the same written documentation of all of the potential side effects. So what I like to tell people is read the package insert on a Tylenol. You're never going to take one of those either, because you'll be convinced you won't live through the experience. All medications have a million side effects. Even if you watch the commercials on TV, it'll sound like they quickly rattle off, usually with some lady jumping through a field and looking very happy and a bunch of flowers when they're talking about a medication on TV, but they're still saying, well, you could have this, and then die. So I think that you coming into a major center, having a stack of papers put in front of you with a lot of different side effects of an investigational drug is a moment for the world to think about how scary that must be, what a leap of faith that must be, and to always think about asking your doctor, instead of the question that I don't want to be a guinea pig, I don't want to try something new, think about asking, well, how does this stack of side effects and issues compare to what I would be taking normally? And make sure, and I say this over and over again to patients, and I think they remember this line more than anything else that I say, this is leukemia. Be afraid of the disease, not the treatment, and make sure that your characterization and understanding of the treatment isn't somehow putting an investigational trial into the scary light with the stack of papers and making conventional treatment look easier than it actually is. And I hope that the audience will think about your clinical trial experience and even all of the side effects that you went through and the difficulty that you went through. I hope what they remember is what you said at the end, which was hanging out on the cutting edge of this breakthrough. And you did, in fact, you trailblazed this drug. This drug went on to be FDA approved and is a major player, and really has transformed, has helped in the transformation of the treatment of acute leukemia. And you were part of that.
Well, as I said, my timing, and I know a lot more about it. That's the first drug that's been approved in many years in 2017. And now there are 8 or 10 more drugs. So the progress is great. And I was part of a clinical trial. My life completely changed. Sometimes you come to forks in the road. So I started feeling better. I became normal. I went out on the speaking tours. I spoke at the launch of our drug. So I spoke at Dr. Roboz's cancer center. She was going to talk about the progress in AML treatment, and I was, I guess, the example. So I'm feeling good. I feel about on the fence between AML as part of my life and trying to ignore it at times, which is how we handle it. It's probably going to be here forever, unless there's some miracle happens. But I've been the beneficiary of 2 miracles so far. And one is my first drug, and now is my second drug. So I'm very fortunate and count my blessings.